Everyone. Welcome to this live event. I'm Marie Manning. I work in the Training Services Division of the American Red Cross, and I'm really glad to have you here with us today. A couple of housekeeping things before we start. You can drop questions and comments into the chat box on your screen at any time, and we're going to get to them. If we can get to them and it makes sense in the middle of the discussion, we will. Otherwise, we'll hold them to the end and get to them at that time. So this is a very special live. It coincides with the launch of the Red Cross Neonatal Advanced Life Support course, which is a new offering in our resuscitation suite programs. So it now adds to our basic life support, advanced life support, and pediatric advanced life support, which rounds out this portfolio very nicely. We're going to call it NALS for short. So when you hear me say NALS, Neonatal Advanced Life Support course. We have two guests today, Jonathan Epstein and Julie Bacon. Both of them worked very closely on the NALS program. And let me read, I'm going to read from my notes their bios, and I think you'll find them very impressive. Julie Bacon, who sits on the American Red Cross Scientific Advisory Council, has over 30 years experience in emergency transport medicine with expertise in pediatric neonatal transport and critical care. She's the program manager and chief flight nurse at Johns Hopkins All Children's Lifeline and manages both a high acuity transport team as well as the transport and dispatch center. She is an expert on newborn resuscitation and pediatrics. She holds multiple clinical and leadership certifications and served for almost 2 decades as the chair of the Florida EMS for Children Advisory Committee. In addition, she speaks nationally and internationally on neonatal pediatric critical care and transport, as well as leadership and motivation. And this is one of those speaking engagements. And Julie, we're very pleased to have you here.
Thank you, Marie. Happy to be here today.
Great. Jonathan Epstein, he's been a paramedic for more than 30 years, and he leads the healthcare product management team for the Red Cross. He has extensive clinical education and training expertise, and he uses that to develop Red Cross learning and development products and materials for healthcare and public safety professionals. Jonathan is an emeritus member of the Red Cross Scientific Advisory Council, which is the guiding body behind all our Red Cross courses. So you can see here we're joined by 2 experts who sit on our scientific, or have sit and sit currently on our Red Cross Scientific Advisory Council. Jonathan previously served as the head of product and customer experience for Health Scholars, as well as with the Northeast Emergency Medical Services, which is responsible for coordinating the EMS system for 49 towns and cities northeast of the city of Boston. Jonathan continues to teach throughout the healthcare and EMS community, most recently at a conference for EMS physicians, where he and Julie both demonstrated some of the skills in the new NALS course. So we're really glad to have you on this event. Thank you for joining us. Let's get started, shall we?
Sounds great.
Okay. So Jonathan, I'm going to toss the first question to you, which is, what was the impetus for this new course?
So it's a great question, Marie. You know, when we think about neonatal resuscitation and more broadly the entire American Red Cross Resuscitation Suite, there was a real gap in access to some education across the country. And when we think about neonatal resuscitation and the Neonatal Advanced Life Support program, we wanted to kind of fill in that gap of covering all age groups that may require resuscitation training. You know, we're going to talk in a few minutes about really why this program was built, but really we're trying to solve a problem. We're trying to improve patient outcomes in the growing crisis across the nation in what we call maternity care deserts.
So let's talk a little bit about maternity care deserts. I'm going to ask our producer to put this map on the screen so that you can see a visual representation of it. What, Jonathan, help us define what that is and why is that so critical?
Yeah, so as you look at this map, and the first time I saw this map, and thank you to the March of Dimes for producing this report annually, over 35% of the counties in the United States have no or very limited access to obstetric care. So maternity care desert is really defined as no hospitals or no birth centers offering obstetric care, or no obstetric providers available in that community. So when you look at 35% of the country, the counties in the country have no access to care. Babies are being born no longer always in the traditional labor and delivery unit of a hospital, but maybe in a critical access emergency department or critical access hospital, a community birthing center, but even in settings where EMS may have to take care of children. So when you look at these birthing where these births are happening, 5.3 million women and 350,000 births annually are affected by this low or no access to care. So when we think of the Neonatal Advanced Life Support program, we want to help improve outcomes by offering training that contextually speaks to those audiences, as well as the traditional labor and delivery unit, NICU in a large hospital.
Okay. So, Jonathan, I see here on the screen, and actually I'm going to ask this question of Julie. You mentioned that over a third of counties in the United States are without a hospital that provides obstetric care. That's alarming. So, Julie, you've, I'm sure, dealt with this as a flight nurse. What does that mean for a woman giving birth?
There's really two situations that come out of this that's really very concerning. The first is that if you are a woman who is looking to give birth, first off, you may be, because of the distance, the lack of service, you may not get prenatal care. And we know that regular prenatal care is going to make a positive difference in pregnancy outcomes. So we may have moms out there that have multiple births or congenital abnormalities or things that we would normally pick up in prenatal screening that we won't know about. So here they are in this county, this section of the US that doesn't have designated OB care. And that day comes when baby is about to make their arrival. The challenge for these critical access hospitals, these community hospitals, full of providers who want to give the best care, that as soon as you put that big H up in front of your hospital, a woman in labor is probably not going to question as she drives by, is there obstetric care there? They're going to pull in, they're going to be in your doors, and now you have perhaps someone that has higher incidence of no prenatal care in a facility that is not designated OB. Are they ready for that situation? And that is really one of the things we kept forefront in our minds when we were writing the NALS.
Okay, all right. So, Jonathan, actually, Julie, I want to follow up with you on that one.
Sure.
So you kept it forefront in mind. Tell me how this NALS course addresses this absence of obstetric care.
I think first and foremost, we recognize it. We recognize that while the course is applicable to delivery room, that we are seeing an increase in births that are happening outside of that traditional designated, dedicated OB. So taking a look at saying, what does a team look like out of the delivery room? What does that look like for EMS? What does that look like in a community hospital? What sort of resources do you need to be able to handle that infant, that newborn in those first few critical moments? We have sections of the textbook that are designated specifically for the out of the traditional hospital labor and delivery suite, tips on that, recognizing that you may have a home birth, you may have a planned midwife birth, but it doesn't all look the same. And the biggest thing is making this course accessible to those folks in those situations.
Okay. So Jonathan, I'm going to toss to you. How do you ensure that neonatal resuscitation training is accessible and effective for healthcare providers?
So I think there's really two issues around this education. One is that it speaks contextually to the learner. Julie kind of just talked about that a little bit, where this program is speaking not just to the traditional setting, but it's actually speaking directly to EMS providers, emergency departments, community birth centers, as well as the delivery room in the NICU and postpartum areas of a hospital. So there's that contextual component of kind of where this course speaks to a learner and teaches them and talks them in the settings in which they're going to respond and have to care for that newborn. And then I think the other part of when we think of kind of the NALS program and reaching out, it's really broadening of who we're reaching to with access. So there are some limitations of truly the number of instructors today that can actually teach this program, whether it be by their qualification and or just where they are today. Again, we have 35% of the communities in the country that do not have any OB capability. That means there's also very few people to teach this program. So when we think of the NALS courses, the two of the courses, when we deliver these programs, we'll be able to broaden the reach of who can teach the program, and so they can deliver it in the community where those healthcare professionals, where those clinicians, where those paramedics, nurses, doctors, respiratory therapists all work today.
So you're talking about having folks who might be in the community, an EMS provider would be able to teach this course, for example.
Certainly, we're going to have a pathway for EMS providers. So traditionally, an EMS provider, so an EMS educator, maybe a paramedic, maybe a nurse, or have other qualifications as well. They traditionally have not taught this program based on their background and credentials and availability of material. So we will have a pathway to broaden the learning that will allow existing instructors that are already teaching in the EMS community, specifically in the pediatric side of the community, but as well as going through the NALS program, some extra learning and some very easy, accessible online at no cost bridging programs to kind of get them up to speed. And part of that will be actually having conversations with Julie and team to really make sure that we understand the science, the context of where that science plays in the community and arena.
Okay. All right. So I'm going to pause here for a minute to point out the banner on the screen, redcross.org/resuscitation. That's where you can go if you want to learn a little bit more about both the resuscitation suite, our BLS, ALS, and PALS offerings, as well as this new NALS offering. I'm also going to ask our producer to drop a link into the chat box to a form where if you want more information about NALS, you can simply go click, this one link and put in your information, and somebody will get back to you on the program itself. Thank you, Desley, for doing that. All right, Julie, let's go a little bit more in depth into the training. What are some of the latest advances or updates in neonatal resuscitation guidelines? These guidelines, I understand, form the basis of this course and help, and they really are the science behind the course. Tell me a little bit about that.
It really is. And I think it comes, it's sort of a dual pathway. First off, and as part of the American Red Cross Scientific Advisory Council, it has really opened my eyes to looking into the science and where that came from. The ill core science, solidly based. And we look at that every study that comes out. And number one, we validate and verify, are the steps that we're currently taking in neonatal resuscitation appropriate? Is the science still applicable? Are we looking at the latest resources? So that's number one. And then number two, what are some new things that are coming out? What is something that we can not do it the way it's always been done? We can do it better. And I'll probably mention this again, probably one of the biggest things with that is delayed cord clamping, which historically has not been part of neonatal resuscitation, but we're finding has some amazing long-term positive effects.
For those who may not know about it, tell me a little, just give us a quick definition of delayed cord clamping.
Absolutely. And quite frankly, I'm sort of excited about it because as an EMS nursing provider, this was not part of my management either. And as we take a look at this, so much positive. So traditionally, what we might have done is that when a baby is born, we clamp the cord, we cut the cord, right? That's a big thing, that cuts cord. We move the baby immediately, and then we begin our assessment and our interventions. Well, during that time period, there is still the ability for mom to provide that nourishing maternal blood right? Through the placenta, through the cord to the baby. So instead of immediately cutting the cord and moving, and only in a very few situations would that be not indicated, for example, maternal trauma, scene safety, some of those things for EMS. But we take the baby, we put them on mom's chest, that's warmth. The cord is still intact. It's providing 30, 60 seconds, maybe more of maternal blood. And what we find out is that neuroprotects the preterm infant, that decreases the amount of jaundice, that decreases the amount of blood transfusions. And during that time period, we're also assessing. So we're doing what we always have done, but we're doing it in a different location. We're doing it on mom's chest with the cord attached. And at that point, we then cut the cord and move over. And this I don't think we've tapped into totally, as we're looking at science, all the benefits that's going to provide.
That's so interesting to me.
Mm-hmm.
Tell me a little bit more about, is this different from inside the hospital versus outside the hospital? And what are some more of those differences between being in the hospital or being an EMS provider in the field or a midwife?
So in this particular, and there's a lot of differences, and we need to recognize that. But the science doesn't change. And that's our first message. The science of ventilation, the science of delayed cord clamping, the science of we don't go immediately to the chest and compression, that stands firm. We just need to be able to address that. What does that look like in-house with a number of resources in a prepared delivery area, maybe more staff, maybe the ability to have a little more education, more equipment. What does that look like out of the hospital for an EMS service where you can't say, well, you need to have 5 people for the resuscitation. Well, there's not 5 people, right? There's maybe you and your partner. So we're saying to, let's say, out of hospital, we understand, for instance, in the hospital, you have limited space, you have limited time, you have limited people. But we want to empower you through education and understanding to be able to apply this really good science that's going to improve the outcome of the infants. It's not acceptable to say because we are in a different situation, the science changes. It does not. We want to help empower them to be able to apply that.
Got it. Okay. So now, Jonathan, you and Julie both presented at and participated in the annual meeting of the National Association of EMS Professionals, and you did some training there. What are some of the skills that medical professionals need to master during this neonatal resuscitation training?
Yeah, so when we worked with the EMS physicians pre-conference workshop around ventilation and airway, and Julie did a fantastic job with this. What I think the first principle was just getting the EMS physicians and EMS educators comfortable with a newborn, comfortable with the size of a newborn, the size of a preemie, the size of an actual an infant. And then really focusing on a paradigm shift is how I like to call it, a ventilation first, don't go right to CPR. Because we know over 99% of infants, when born, when they have a lack of oxygen, they don't have a heart rate that is where we want it to be. Our old training was start CPR, start CPR, start CPR, start those chest compressions. But the science really tells us they need ventilation, ventilation, ventilation. Again, 99% rarely or more don't need just chest compression. We need to open up their lungs. So having the physicians and the paramedics and paramedic educators that came to those workshops and sessions with us, really getting to practice those ventilations with new equipment and just the sheer size of the equipment being so small. Again, it's something we don't do every day. So having that hands-on experience, I literally had one of the educators ask if he could hug me, because this was so needed in their system, and that we were bringing this kind of new knowledge and learning that made sense to them in their emergency department and in their EMS service, that they were so thankful they got that hands-on practice of just how do I apply an LMA or an endotracheal tube and intubate a preemie, what size tube do I use, what size blade do I use. So just having that ability to focus on sheer size and get past the, oh my goodness, I've never done this before, or I do this once in my career, getting past that, and then just the hands-on practice into the scenarios, which was fantastic.
That really is fantastic, and it's great that you're sharing this knowledge and that this course is out here sharing this knowledge. Julie, let's talk a little bit about teamwork, because I'm curious about that. Obviously, in the hospital, in an OB unit, you have a whole team of professionals. As you mentioned before, it's much smaller in the field. What role does teamwork play, and how is this emphasized in training?
I think what you just said was really important, is that first off, we recognize that not all teams look the same. They have different challenges going into the situation. So we emphasize teamwork from prior to the birth. Now, that could be 10 minutes, 15 minutes, 2 minutes if you're pulling up in a truck, right? But as a team, having that game plan, that plan of action, as a team, knowing where your equipment is and how to apply it. And then as a team afterwards, doing effective debriefing. What did we do well? What was our gaps? How can we improve this and be better prepared in the future? So the important thing is teamwork doesn't just apply to when you're holding that baby in your hands. It starts well before and goes well after. And we apply that in every scenario when we're looking at the NALS book.
Okay. So really from pre-birth to post-birth is the whole continuum is covered.
Yes, correct. And a lot of additional information. And truly, the resuscitation of a newborn is simple. It really is. It's all about ventilation. And as we go through NALS, we're really excited about all the information they're going to be receiving about newborns, but we don't want them to be concerned about, I have to know all of this to effectively resuscitate. We really have tried to speak to the person, because this is, as Jonathan mentioned, very low occurrence, very low volume, high stress type of situation. So we're really accentuating those important points that are going to make the difference in the outcome of that newborn.
What's so interesting to me here is that we talk a lot about this training and how it's been developed. It sounds like there's a lot of new information in this training that may not have been given before. Jonathan, can you speak to that at all?
Yeah, I'll keep it at a fairly high level. But when
Yes,
we think about the NALS program, and it's 2 courses. We have a foundations level course and a comprehensive level program, where they're geared to really 2 different audiences. But when we think about what this is covering, it's really from that pre-birth through that discharge from the hospital setting. So there are certain aspects that Julie just really talked about, that ventilation, those first 2, 5, 10 minutes of critical intervention. But the course goes beyond that, where we do talk about congenital heart defect or CHD. We do talk about neonatal sepsis, some of these leading causes of death and leading causes of complication. So the course does go beyond just that initial few moments, but really get you to the point of discharge from the hospital. So all those elements of resuscitation and post-resuscitation management are included within the curriculum of the program. And predominantly those topics are in what we call our comprehensive program. And I can, if you want to go into the differences, Maria, I'd be happy to.
I would like to. I'd like to give our viewers a little bit more information about the differences between the foundations course and the comprehensive course.
Yeah, so I think to think simply about it, our foundations course is a course for someone who may be attending the birth of a baby, that will have an advanced team arriving shortly thereafter to really address some of those critical components of resuscitation if necessary. So when we think of it clinically, this could be EMT, a paramedic, a nurse, a physician, downstairs in the emergency department, could be out in the street, could be in a community environment, but it's really thinking about the foundations course. Do I have additional resources coming to assist me that have the equipment or capabilities to handle the resuscitation through the, through post-resuscitation care? The comprehensive course, consequently, is if you are that advanced team or you have no one coming. So if I'm in a critical access emergency department in rural United States, there may not be a helicopter flying. There may not be a ground transport team coming. So I would need that comprehensive program to teach and learn about resuscitation from the very, very beginning, from that pre-birth huddle, all the way through maybe that transfer of care, which could happen an hour later or even a day or two later. So the comprehensive course is for really anyone from birth to that post-resuscitation care. The foundations course, which will be a smaller population for those attending at birth that have advanced care coming to them in a short period of time. It's the simplest way to think about it.
All right. Now, the comprehensive care course also has something unique about it, if I recall, in that if you have a lot of experience in the field, you can do what's called adaptive learning and get it personalized for you. Is that correct?
It is, Marie, and it's a great point. Really the foundations course and the comprehensive course are layered together. So the foundations course, the material, the e-learning and the skills are all part of the comprehensive course. Just the comprehensive course goes beyond that foundational level. So if you are an experienced practitioner or clinician, there is a optional pre-assessment that someone can go through and actually test out of the knowledge base of that online learning component. So it'll create a learning path of what you need as that learner. So there are 4 modules. If you test out of one module or all 4 modules, it will tell you where you need to practice and study, and then move into our cases themselves. So that adaptive learning, which we find in our BLS, ALS, and PALS courses as well, it's really a hallmark of the Red Cross Resuscitation Suite. We want to teach you what you need to know, and not kind of cover material you already have expertise in.
Got it. Okay. Julie, I'm fascinated by your background as a flight nurse, and I know that you've seen your share of births. Can you give me an example of one real life scenario where neonatal resuscitation training really made a big difference?
When we talk about EMS providers, ERs, community hospitals, midwives, outside of the traditional delivery suite, these are providers who are really passionate about giving the very best care that they can to their patients. But for a number of reasons, whether it's accessibility to the education or the inability to sim it on their own, for whatever reason, they become very good at adult resuscitation and have this gap. So what has historically happened is when that mom comes through the door of this community hospital in rural America, these providers, wanting to do the best they can, apply their adult resuscitation knowledge to the neonate, and that often is devastating outcomes. So what we have done is gone into and promoted ventilation. That one thing alone, ventilation alone, and not going, as Jonathan said, straight to compressions, does a couple of things. First off, it can take, if you have a bag valve mask, and in the adult population, we tend to use that to code a patient. In the neonatal population, we call it our anti-coder. That we go straight to ventilation with our bag valve mask, and all of a sudden we have seen when that has happened, when they've given these ventilations appropriately and quickly, that the lungs start to open up, and a child who may have gone down a very devastating path starts to perk up and is basically in mom's arms and not very long. Think about the impact that also makes on the provider in a culture right now where we are concerned about the mental health and the stressors to our providers. Don't they deserve the very best tools and the very best resources, as they are the ones there with that infant in their hands, and there is no more stressful situation than that.
Oh, this is such an exciting new development, I feel, in neonatal resuscitation. Jonathan, tell me, how does somebody get this course? Do they get it through their workplace? Do they get it some other way?
Yeah, so we believe the majority of people access this program through their workplace. Whether it be through a hospital, through an EMS agency, through a community birthing center. Typically a training entity will deliver this program. Again, we're working with 2 great organizations for this program and the release of this program. Certainly with AWHONN, the Association of Women's Health and Obstetric and Neonatal Nurses. They're our co-developer of this program. I don't think we've talked about that today. So we have those neonatal and OB nurses that are really fundamental to this process, helping build this program, bring their expertise. But so the relationships with AWHONN as well as with HealthStream. HealthStream is one of our partners in helping deliver educational material to healthcare systems across the country, as well as through the Red Cross directly. So really, best way is going to the redcross.org resuscitation website, or even redcross.org, and just looking up for the NALS material to kind of become an educator, to become an instructor, to see where you can take this program. And I think it all is going to start as we launch this program, is really taking instructors that are in the market today, instructors that are already teaching neonatal resuscitation in other ways, to bridge over to the American Red Cross. So we have a very simple process of bringing instructors over at no cost to start being able to deliver this program to their communities, literally in the matter of several days.
That actually, Jonathan, dovetails very nicely with a question that William just asked. He said, when will the bridge be available for PALS instructors and faculty IT, and faculty IT members? And he said, is it available for AHA or Red Cross?
Okay, so great question. As we start off, those instructors that have a credential called Neonatal Resuscitation Program, NRP instructor, NRP instructor mentors, will have a bridge starting today. Those bridge programs are now should be live and moving forward. Shortly, over the next several weeks, the process about taking PALS instructors and PALS instructor trainers that have taken the NALS comprehensive program, so that base level certification first, will have an opportunity with a few steps along the way to become NALS instructors, instructor trainers. So there's a process, but really the process starts with getting into a NALS comprehensive program first, get that base knowledge, that core information, to practice those skills, be assessed from a competency perspective on those skills, and then we'll work to those proficiency components in the bridging processes. So NRP live today, PALS in the next coming weeks.
Okay, got it. I want to go back to one thing both of you mentioned, which is allowing EMS educators and really having this program designed for EMS educators. I heard you correctly that you're going to allow EMS educators to teach this program, right? Because that's huge.
We are. Again, part of that will be taking that NALS comprehensive program, or having the NRP Advanced program, but having that NALS comprehensive program, and then going through either a instructor course, a traditional Red Cross instructor program, base level certification, a blended learning instructor program, online learning, as well as a 2-day in-person instructor course, or using their PALS instructor and PALS instructor trainer credentials to bridge over when that option becomes available in a few weeks.
Okay. We do have a question that I think I'm going to take, which is thanks for putting this on. Does this count for EMT continuing education credits? Unfortunately, this one does not, but
it does.
It does. Okay.
It does.
Jonathan, please correct me.
Yeah. So Marie, the NALS programs, both the foundations program, the comprehensive program, as well as all the instructor bridging programs, all are already CAPC approved and ready to deliver EMS continuing education. So they are at the advanced level. So when we think about EMT versus paramedic, you have to make sure you're checking with your state and local guidelines, as well as national registry. But they are all available for the advanced credit for the provider level courses and educator credit from CAPC for the educator level, instructor level programs.
Okay. William says the issue is in the pre-hospital environment. There are very few NRP instructors. They will likely be less NALS instructors after that. So what is the plan to fix that issue?
So we're starting to fix that problem. Again, this is really one of the problems to solve around the maternity care deserts. We're kind of full circle in our conversation. We'll actually be holding some provider programs as well as instructor programs in the communities around the country. It'll be slow to start, but we'll start ramping up programs both for EMS as well as hospitals and other environments as we go throughout the rest of this year and then obviously into the next year. So we already know we have a program scheduled in a couple of weeks that will be starting our first And then we'll be continuing to kind of broaden the reach of having more and more educators available to teach this program.
Excellent.
I think, the other plan around this is certainly, making that kind of connection between, with our AWHONN colleagues and our collaborators in this program together, of matching existing instructors that maybe are AWHONN members that want to reach out into their communities, to their hospitals, to their tertiary care centers or their community hospitals, as well as their local EMS agencies, where they want to bring this new program with its updated science and format to the market as well. So we'll be doing a lot of kind of, I don't want to call them love connections, but connections of trying to bring existing instructors that we can bridge over on the faster side to deliver this program as well. Similar to what we did with our ALS and PALS programs back when we released those about 5 years ago. And it worked because we have over 4 million certifications and counting.
That's amazing. Well, we have hit we've gone a little bit over, which I really appreciate your time doing this. It's such an important topic, and we're really looking forward to having this program out there. I'm going to ask our producer again to put the link into the chat box, where if you want more information on the program, you can get it. And where someone's having some trouble with this page, may I suggest then that you go to redcross.org/resuscitation. There is a form on that page that you can fill out, and just click the button and it will work. So redcross.org/resuscitation, and you can fill out the form on that page. Jonathan, Julie, I really appreciate the time that you've spent with us. I've learned a lot from this conversation, and I'm very excited about this launch to come out, and appreciate all the time that you spent with us on the call today.
Glad to be here. Thank you.
Yeah.
All right.
Thank you, Marie. Thank you, Julie, so much. And again, we want to improve outcomes, and the best way is to get this new access to additional training.
Great. Thank you.